Allergan has always built their reputation on their R&D pipeline, and I trust Allergan that they have the next big thing that's going to come out.
We're working on a lot of innovative therapies.
Better pathways, better innovations to help treat the disease process.
There's really just one company that keeps reinvesting, giving us new options for the future. It's Allergan.
We have the intro video. Well, welcome one and all to the Rising Stars in Ophthalmology Season 1. Well, after our last encounter, I must tell you that I'm extremely excited and happy to announce that we have about 1,200 people from across the world who want to be a part of this Rising Stars in Ophthalmology community. That really does resonate well with you guys, and we're really humbled with that fact. For the folks who weren't with us last time, the Rising Stars in Ophthalmology Season 1 is a 9-episode series. Let me repeat, it's a 9-episode series that will focus on bringing to you all an absolutely new and innovative technology platform with speakers that, according to me, clinicians, new world of ophthalmology today. The program is being aired on well as on your website of risingskystars.com. All of the complete episode with the prior ones will be on the website for further viewing by one and all. So if you want to ever watch it again, go back to the website and you'll be able to see the same thing all over again. And also keeping in mind that the time zones are different, it's easier for people to keep in touch with who the rising stars are, who our celebrity panelists are, which is very, very important in this case. This time around, we have a new sensation who will be talking to us about the new age refractive cataract surgery and what this means to her. To introduce the celebrity panel and our speaker of the day, I want to call upon Jennifer Lowe, but first she wants to say a few words before we begin the introduction. Go ahead, Jen.
Thank you so much, Ashwin, and to all of our celebrity panelists and esteemed speakers. Before we get started tonight, I did want to introduce our guest speaker, Dr. Laura Perriman, who will be speaking on an exciting dry eye topic in partnership with Allergan, one of our sponsors for this evening. Thank you so much. You can take it from there, Laura.
Hi, thank you so much for the opportunity to be here on Rising Stars of Ophthalmology. What a really brilliant and incredible way to bring the global world of young ophthalmology leaders all together. So hats off to you for organizing and for coming up for this project. And thank you to Allergan, our sponsor, for tonight's event. Allergan has always led the way in innovation, in collaboration, and in education. And their support for physicians, young and established, has never wavered. This is one of the things I appreciate so much about Allergan as a company. Over the course of my career, I have seen dry eye gone from a disease state where we couldn't do a whole much about it to something where we understand the details of the immunopathophysiology with exquisite detail. And as ophthalmologists and as these highly skilled surgeons that are coming to the fore with the rising stars, the focus is on enhancing lifetime visual performance. And so the mindset becomes, how do we create this premium visual performance machine? And it really starts with the tear film. That's where dry eye comes in. That's where Restasis comes in. It's been around for over 17 years. There's 7.6 million US prescriptions. There is well over 1,000 peer-reviewed papers on the subject. And as a molecular immunobiologist and ocular surface disease expert, I find that this trusted, tried and true friend is an important part of the mindset of all of us as ophthalmologists who really very much care about our patients' visual performance. We know that dry disease is a multifactorial disease state. We know that inflammation is at the epicenter of the entire disease state and it has to be addressed. And so with our current knowledge, fast forward 17 years, we now know that dry eye has impacts on our keratometric readings prior to cataract surgery. Alice Petropoulos' excellent paper showing that hyperosmolarity, which is a key part of dry eye, absolutely affects the keratometric readings, up to 2 diopters of your IOL calculation. So it's another reason to address dry eye beforehand. We also know from Dr. Trattler's excellent phaco study that dry eye disease is present in about 77% or evidence of it with keratitis in your pre-op cataract patients. Now that can have a huge impact in the visual performance, in the IOL calculations. That's why we care. Here's the catch. Only 22% of those patients came in with the diagnosis of dry eye. And that's a problem. And that's a call to action. We all need to be more proactive in identifying this and treating it well before the cataract demographic so that there is no premium IOL technology that's not available to these patients. And then finally, I want to talk about the humble goblet cell. Restasis is wonderful because we know that it enhances goblet cell density. You can get almost a 200% increase in goblet cell density. You might think, big deal. Well, it is a big deal because goblet cells not only make mucin, which allows tears to wet and spread across the ocular surface, keep a stable tear film, but they also have an immunoregulatory capacity. That's why we care about goblet cells. They're the unsung hero of the ocular surface, so that you, as an outstanding young rising star ophthalmologist and amazing cataract surgeon, can perform your very best work.
All right, thank you so much, Laura. We really appreciate your expertise. And now I'd like to introduce, before we get started on introducing our esteemed speaker, I wanted to introduce our celebrity panelists. But before I move along, Dr. Pearman, is there anything else you'd like to add?
And I can't wait to see what the new generation does with dry eye. We've come so far in the last 2 decades, and I can't wait to watch what the next generation does with our body of knowledge and the tools that we have to address it. And I will applaud you and celebrate you in all of your accomplishments.
Okay, wonderful. Well, on that inspiring note, first I'd like to introduce our 3 esteemed panelists for this evening. We have Dr. Kendall Donaldson, hailing from Miami, Florida, and Bascom Palmer, and she's obviously an expert in all things refractive and cataract surgery. As well as we have Dr. Uday Devgan, who is the famous brainiac behind Cataract Coach, and we encourage you all to subscribe to his channel and watch his amazing videos. And then we have the superstar, Dr. Priya Narang, hailing from India. And she is not only an amazing surgeon, but also a published author. Okay, so next up, I'd like to do a brief PowerPoint on our superstar, Dr. Ashley Brissette. So allow me to share my screen here. All right, so Dr. Brissette really needs no introduction, but she is our second episode rising star. You can see here, we love this photo. I mean, this just showcases Dr. Brissette's talents perfectly. She's in the OR, wearing her stylish lab coat and surrounded by tons of amazing technology. So amazing photo and great introduction. Dr. Brissette hails originally from Canada, and she did her bachelor's degree at McGill University, as well as her medical school and ophthalmology training at Queen's University. She ended up completing her fellowship at Cornell, where she now holds a faculty position as assistant professor of ophthalmology in cataract, refractive, and cornea and external diseases. She has amazing follow on Facebook, and she does so. I'm pretty jealous, right? So, but in addition to all her amazing travels, she has graciously made time to prepare an amazing talk for us tonight. So take it away, Ashley.
Wonderful. Well, thank you so much for the invitation to be a part of something like this. It's really my pleasure to be speaking here and to be included and to even have input from the celebrity panelists, because I know they're going to have some really amazing insights. So I'll just start here and share my screen to start the presentation. So I was excited that I got this topic of refractive cataract surgery, because as I started in my career, I kind of thought I'd be the cornea surgeon that was doing more really complex cornea cases. And as I kind of started early in my career, I really gravitated towards refractive cataract surgery because the technology was so interesting to me. And there's so much that was coming out over time. And the landscape was changing even since I finished training. I'd say more than 75% of what I do now, I didn't even learn in my fellowship. And so it's just incredible to see how much further we can go with this. So one thing that I want to impart on everybody is just don't be satisfied with being just a good surgeon. You should really strive to be great. And I really like this quotation that says, if you're not getting better, you're getting worse. And that's something that I kind of try to achieve in terms of how I prepare for surgery and how I kind of try and develop as a surgeon. And the other known quote is, if you're not first, you're last. And this is a little bit tongue in cheek, but I do like this as kind of a funny quip to always striving to do better. So what does it mean to be just a good surgeon versus a great surgeon? Well, if you're a great surgeon, I think you're really striving for improved safety, for greater efficiency in your operating room, for better outcomes, which at the end of the day, it's really just about happy patients. So just getting our patients better outcomes and getting them to have a really, really good experience with us. So how do you get to this position where you can be great? Well, I really think that you need to practice. I think you need to prepare, and you also need to plan. I'm constantly practicing new skills. The top kind of right photo is me and one of my colleagues at Cornell doing a wet lab just to practice some new surgical techniques. And I still do this as an attending. I take myself to the wet lab to practice. I prepare for all my OR cases, make plans as well. Because I think it's really just talking about practice. This is a famous kind of photo here from Allen Iverson interview that he did, where he missed practice and then was benched and then repeatedly says over and over again in the interview, are we talking about practice? And yes, we are, because practice is how you're going to go from good to great. So how do I kind of set myself up for a good day in the operating room? Well, I think the first thing that you need to do is have the correct mindset. So what I do is I'll meditate in the morning. I don't drink any caffeine the morning of the operating room. I make sure that I get there early. I'll even visualize some of my cases, especially the difficult ones, the ones where I might need extra kind of tips or tricks or tools with me in the OR, you know, if it's a capsular tension ring or, you know, any extra tools that I might need. I kind of visualize everything ahead of time so that I have it prepared. I also try to set a positive tone for the team, because the team that's working with you is such a vital part to the patient experience. And then lastly, just having some good music playing in the background. And oftentimes I just let the nurses pick this because I don't really hear it when I'm in the zone, if I'm being honest. I think the first step as you're sitting down to start surgery is actually ergonomics. That should be your first step of surgery. I think you should have a neutral head and neck and back position. I put the gurney at about hip height for myself so that my legs can fit underneath the bed at about a 90-degree angle, keeping your elbows at 90 degrees, your wrists straight. And what's really important, and I try to impart this on the residents that I teach, is to have a relaxed grip on the instruments. Because we're moving in such a small defined space, there can be a tendency to grip the instruments really, really hard. And you want to make sure that you have a really relaxed grip instead, because that can lead to some wrist or even kind of shoulder or elbow discomfort. And I try to stretch between cases as well, because it's a pretty stagnant position. And the last thing you want to do is, after training and doing all this kind of training to get yourself to be this great surgeon, is not be able to operate anymore because of any back or neck discomfort or musculoskeletal pain. So I do think proper positioning is extremely important. So I was wondering if the panel can maybe just share a pearl that they might have on how you prepare for a day in the OR to get yourself to that place where you can be a great surgeon.
My most important thing is get there early. If you're not at least 15 minutes early, you're late. Mm-hmm. So I get to my surgery center usually at 5:45 in the morning, and we cut the first eye at 6:15. So I'm there about 30 minutes early to set up my microscope, do a white balance, make sure the focus is perfect, make sure my settings are there, mentally prepare, put my list on the wall, and we're busy. We're doing, with 1 OR, 3 cases in an hour. If I use 2 ORs, we'll do 6 surgeries per hour. So we've got to have a nice rhythm going, but be early. That's my pearl.
Yeah,
for me, I have 2 important things. I like to be there early, that is for sure. And the second thing is, I would like to go through the case file sheets of the patient, analyze what I'm going to do next, and I disconnect myself from the world. That is one point. Mobiles and everything go aside, and you are just focusing on what you are going to do. And that is how these are the 2 basic things which I follow every day for the OR. And that is, I think that makes all the difference.
Yeah. Actually, I loved everything you said there. A few things that I'd like to point out. The ergonomics. You know, I have so many friends at my age having neck and back surgery after years of comfort in the OR, and I think it's something that we didn't really emphasize. And I'm glad you pointed that out, because you really want to be comfortable. You want to be comfortable. You want your patient to be comfortable. You want your OR crew to be comfortable. And I remember years ago, there was a study on airline pilots, and the pilots that had the most accidents occur when it's a team that hasn't been working together, a team that didn't have a relationship. So most of the airline crashes through the years were in groups like that. So we talked about this as we were setting up our OR and redesigning our teams in the OR, and the importance of creating that team and that camaraderie amongst the team. You know, having that good relationship with your team members is just so important. And I think that's underestimated. So, and also the order of cases, I think, is really important. Those difficult cases that you mentioned, and putting them at the end of the day. So, you know, you can kind of get your easy cases out of the way and feel really good about yourself, about how you're doing, get on a roll, and then do some of your more challenging cases at the end when you don't have as many people waiting on you. You could be comfortable.
Yeah, I think that's all great tips. I totally agree with that. So I wanted to give Kevin a couple little tips that I think can take you from good to great in terms of efficiency and efficiency of movement when you're operating inside the eye. So my first tip here is that you can look really slick with your viscoelastic. You don't want to overfill the anterior chamber, because what that does is it actually puts the cornea on stretch, which can cause distortion of your main wound, which will make it tougher to seal and can also make it more prone to decimase detachments. So that first video was a good fill, and I just want to show you here what an overfill would look like. So this is a pretty small eye with a shallow anterior chamber. So I'm going to actually try and overfill to kind of push things back. But you'll see here, as I come out with the viscoelastic cannula, you see all that aggressive viscoelastic. And so that's an overfill. So I try to tell my residents, you don't want to overfill, you just want to have a good fill, because it's that old adage, each step will make your next steps easier. The other thing that I like to talk about with when you're trying to go from good to great is to the capsular rhexis. So a few tips here: use the Purkinje reflex for centration. I try to make it approximately 5 millimeters. I think that's ideal, and really important to pivot within the incision, and that will prevent viscoelastic loss. And folding back the edge of the rhexis over so that you can kind of create a sail for yourself so that it's easier to pull. And so I think those are just some kind of good tips for capsular rhexis creation, getting it centered every time and getting it the appropriate size. And then lastly, this is something that I learned from Ike Ahmed, which is to hydrate the cortex after you hydrodissect. And that's actually just going to make it easier to remove the cortical material. So you can see here, I got my fluid wave, and then I do this thing where I go around 360 degrees, and I actually sweep in what I describe as microdose or little pulses of BSS about 360 degrees around to loosen the cortical material. And that will actually make it easier to remove in the long run. Another thing here is that I try to have a few different methods of nuclear disassembly in my toolkit, because some techniques are better in certain situations than others. So I like to do a standard stop and chop for my kind of standard cases, which is the first video here. I find it's a nice way to teach residents as they're starting surgery. I find to just get good kind of easy nuclear disassembly with this. I'll often do a vertical chop for a denser cataract, which is the second video here. And then I'll do what's called a phaco flip technique for really soft cataracts, where I just kind of flip it up into the anterior chamber and then just allow it to kind of come over onto itself and flip, and then I can eat it that way. So there's a few different ways that you can do nuclear disassembly, and I'll try to change my technique based on the cataract and based on the density versus not, so that it's easier to remove. And one thing, just always keeping the chopper back to protect the capsular bag. And then lastly, for the IA, my big kind of tip here is to just go where the meat is. So you just want to really get good occlusion of your tip so that you're getting good removal. And you can see here, because I hydrated one extra step at my hydrodissection, you can see how easy the cortical material comes here because it's already pre-hydrated. So again, earlier steps, just a few extra seconds will make this step so much easier to remove. And then one thing, if you do have a piece subincisional that's hard to get, what I'll do is I'll go to polish. I'll polish it from the posterior capsule. I'll kick back over into cortex, get good occlusion, turn it over 180 degrees, and then eat that last piece. And so I find doing that flip to polish, then back to cortex, allows me to get that subincisional pretty easily. So I just wondered if the panel had just like one pearl that each of you could share about making your surgery much more efficient, and if you had any tips.
They don't have one pearl, Ashley. I think they might have quite a few up their sleeves. That's why they're here. But
right.
but yeah, happy to hear.
I guess the most important pearl.
Yeah, actually, I would say one important thing is with the point that you made about having good occlusion, and many of us work with a peristaltic pump, and I've seen so many residents or fellows, be phacoing and they don't have full occlusion, which means nothing's really happening. You're just expending energy, that's not even useful energy until you have full occlusion with a peristaltic pump. So, making sure you have good occlusion, just not expending energy into the anterior chamber that's excessive. And the other technique, we're only allowed to have one, knowing how to use Little's maneuver and feeling comfortable with it so you can save a capsular rhexis. If it starts to go out, it's always better to just spend some extra time, add the viscoelastic, like you said, and pull centrally again. So you don't have to be worried because you have that technique in your bag there to use at any moment like that. So the extra viscoelastic and pulling back to the center with Little's technique, I think, is really key.
That's great. Yeah.
For me, the pearl is simple: never be satisfied with good enough. So always aiming to be better and better. And I actually learned this from Amar Agarwal, who was a mentor to me 20 years ago. And the concept is, listen, he says, if you can get 1% better a week, and then you're compounding that, in less than 2 years, you're twice as good as you are today. And 1%, I can achieve 1%, even 1% a month over the course of a couple of years makes a tremendous difference. So that was a pearl that stuck with me 20 years ago. And even now, when I make the Cataract Coach videos, I learn more than I teach. And I keep watching my own surgical videos so I can improve on the mistakes that I may have made or what could I do to make it better. But more importantly, I learn from surgeons from now across the world.
True. Priya?
It was a great tip, especially for the overfill that I saw the video, Ashley. And actually, surgeons, they usually tend to overfill when the pupil is of the moderate size. So that is invariably an attempt which is made to have a good amount of pupil that probably it might dilate and for things like that. So when you are, actually you gave a very nice tip that when you have an overfill, you might land up with other problems also. So I would just say that if anybody is having a situation like that, wherein, you have a moderate size pupil or cases where you expect that maybe the pupil size might go down during the surgery, I would just recommend for beginners that instead of going ahead with a topical surgery, maybe they can choose to do the surgery under anesthesia or under a block. So there are many things that can be prevented by just putting up a block for that patient. So that is one thing, but other things you have beautifully highlighted. And one more thing is that for the 12 o'clock position, removing the lens matter, I don't know, invariably in my hands, I have found that I'm better off with a bimanual IA because it gives me a lot of maneuverability into the anterior chamber and I can flip around and move around and do anything. So that's my point on that.
Yeah, that's a really great tip as well. Thank you all for those. So I want to just do a couple of cases here just to highlight some things that I found useful that is kind of a newer technology maybe for us in the US, but maybe not elsewhere. But one thing is this new lens that we have available to us, which is the trifocal lens. And so the trifocal lens, it has 3 step heights. And what it does is it helps to redirect the light from additional focal points to help preserve contrast vision, but also to give us these 3 focal points, the distance, intermediate, and near. And I don't mean to just talk about one lens, but we only have one available to us in the United States. And it's the PanOptix lens, and this has become my diffractive lens of choice. So it's replaced all my other diffractive lenses at this stage. And so I just wanted to give a couple of tips for maybe using a new diffractive lens and making placing these lenses seem less scary. So one thing that I do is I actually get a pre-op macula OCT for all patients. And this is true of any of my patients getting any kind of premium lens, or even for my toric lenses, I do this. And even sometimes for my monofocal patients, if it's a difficult view because it's a very dense cataract, sometimes I'll also get a pre-op macula OCT. The reason being you can miss subtle macular pathology, trace ERM. And so I think it's really important to find these early on so that you can counsel the patient on what to expect. But especially for these diffractive lenses, I think it's important. My second tip is to aim close to plano and make sure that you fix all astigmatism. I also under-promise and kind of over-deliver for my patients. So I talk to them about microvision and how for very, very fine print, they might still need glasses for reading. But the goal is to try and get them out of glasses for most things day to day. So I never kind of over-promise what these lenses can do. And then something I learned from a colleague and friend of mine, Blake Williamson, is this term, no rings, no reading. And I do say that to my patients. So I say, the way that this lens works is it has rings in it, and that's what allows you to read. But those rings might actually give you some glare, halo, or rings around other lights. So then the patients can kind of understand that concept somewhat, but very low self-reported visual disturbances. And these lenses also work best when implanted bilaterally. Any diffractive technology splits lights, so that will impact some contrast and vision quality. But I've been pretty impressed with this lens so far. It has a total of 88% total light transmission. And then I've had really great results in terms of patients being happy with this lens and with the quality of the lens as well. So this is just a video here highlighting using the PanOptix lens and then using also the femtosecond laser involved with this surgery. I'll move here to this slide, which I thought was really interesting. This is a photograph of a presentation that our colleague Damien Gattinel was giving at a European meeting and highlighting that in less than a decade, these trifocal lenses have become the gold standard for premium intraocular lenses elsewhere. And I think we're going to see that trend in the US. And in the studies, 99.2% of patients said they would have this lens implanted again, which I think is extremely, extremely successful. So I wondered if the panel had a pearl that they could share on how to select patients when you want to adopt a new lens, because you really do want to have good early success with it so that you start to feel comfortable with the new technology.
You gotta hit your target in a refractive sense, both spherical and astigmatic. And so you know that the best patients are the ones with eyes. So when your IOL power calculates out between, let's say, 20 to 22, those are average eyes, and the lens calcs are really accurate. But if your IOL power calcs out to a 9 or a 29, there's going to be a lot more variability there. So start with average patients, and of course, those who have reasonable expectations.
Yeah, great advice.
You know, Ashley, it kind of made me laugh when you mentioned that comment from Blake Williamson, because I use that, I've heard him say that as well. And I tell all patients that they will have glare and halos. And in some, it's difficult to know exactly how much. You know, they'll notice it. Some patients don't notice it at all. Other patients notice it more. And we try to do our best to predict who's going to notice it more. But I tell them that they all will have some glare and halos. And that means that the lens is working. And it'll become less noticeable over time. But I did learn that from Blake also. I remember that exact interview where he said that. But you know, I think it's very easy to talk about the positive attributes of something, whether it be a lens or something else. But it's very difficult to talk about the negative things, and we need to do that before surgery. So we need to make ourselves say the terms glare and halos and splitting light. So patients, I think we need to tell them that, and we have to get used to saying it and feeling comfortable with saying it. Because you don't want to be talking about it after the surgery. So I think it's important.
I think two major points have already been highlighted by Dr. Uday and Kendall. The only thing that I would like to do is I would just talk a little extra with these kind of patients who are, whom I do plan to put in a new lens, or probably I'm offering them the technology, or sometimes, you know, what we have seen trend in, what I have seen a trend in my practice is some of the patients, they come with the name of the intraocular lens that I want this lens in my eye. So can you put this for me? So that's the point when I start talking with them that, okay, what are your expectations? What actually do you want? And then when I'm talking to the patient, I just start analyzing that what is the mindset of this patient and how cooperative this patient is going to be, and you know, the personality of the patient, that how the patient will be expecting it, because at times we have patients who just do not want to budge, and you know, they would not take it from me that, okay, there is a possibility that there might be a glare. So like you need to analyze the kind of patient that you are going to put along with the profession of the patient. And then I always say, I cannot guarantee you anything, but these are the side effects which usually come up. And you might face this, or maybe a halo. And usually patients, they settle down over a period of time. You know, the entire explaining of the procedure, what we usually do for the multifocals and for the diffractive lenses and other lenses. In spite of that, if the patient says that, yes, the patient is ready, then I would probably offer. And one small tip, which I always do, is I'll immediately call up one of my colleagues who has been using that lens and take a input from them if I have not used that lens before. So that is one thing which I always try to do for my patients. It's always the patient's expectations that matter a lot at the end of the day, because we are trying to do the best from our side.
Yeah, I agree with that. And I like what you said about that. I just played this quick video. This is one of my patients 1 week out from surgery.
PanOptix lens inserted in my eye a week ago. And for the first time, I am walking around without glasses, which is really astonishing since I've been wearing glasses for about 40 years.
And so that's was something that I was really impressed about with this lens. My happiest patients I found, one of them are actually these extremely high myopes. And I was always kind of taught, be careful putting a diffractive lens in a myope because they're going to be afraid to lose that near vision that they've really liked over time. But some of my happiest patients are high myopes, hyperopes. Of course, you know, hyperopic patients are so happy after cataract surgery anyway, but especially with a diffractive lens. My younger patients that are presbyopic and have cataract. And then lastly, as we've discussed, patients that have a desire to be glasses free and that understand the risk. So far with my experience, those have been my happiest patients. And then, so getting to the next case study, I think before you want to even address refractive cataract surgery, you really have to address the ocular surface. And Dr. Perriman kind of discussed this early as we started with this discussion. But this is just an example of a patient that maybe wants a diffractive lens. They want to be glasses free after cataract surgery, and they're asymptomatic. But when you look on clinical examination, they do have some signs of ocular surface disease. So things that I look for are things like rapid tear breakup or possibly lag ophthalmos and lid position. Because signs and symptoms don't correlate well, and signs can actually worsen, and asymptomatic surface disease. So one thing is that I'll do is I'll get my technicians to ask directed questions, objective tests, and my clinical examination to look at the ocular surface before even discussing cataract surgery with the patient. So things that I rely on are in MMP9. Do have some access to things like non-invasive tear breakup time, and then looking at corneal staining. And other clues that you can look at for ocular surface disease would be dropout on topography. So if there's areas on your topographic map that are missing, that could be indicative of ocular surface disease. Or if there's differing axes of astigmatisms on different measurements. So if you're getting, say, a biometry and a topography, if your axis of astigmatism is not kind of similar between the two, that could be a sign that there's ocular surface disease. And this is a great paper that I believe Dr. Donaldson was on as well, that was looking at chief complaints of patients presenting with dissatisfaction after presbyopia correcting intraocular lenses. And the main reason why patients were unhappy was actually related to dry eye disease. So if you're going to be doing any kind of refractive cataract surgery, addressing the ocular surface is extremely important. And I wondered from the panel, do you have any pearls about how you optimize the ocular surface for your patients for cataract surgery?
Well, I guess I'll start. I think it's really important, Ashley, as you mentioned, screening for this in all patients that are having cataract surgery or any of the surgeries that we do, whether it be LASIK or corneal transplants or even glaucoma surgery, just having a questionnaire, like an OSDI or SPEED questionnaire, as well as objective findings, including the topography, that you can actually show the patient and make a partnership with the patient by sharing with them these numbers and pictures that show that this is a problem. And this is what we need to take care of before surgery. So creating that partnership. And then from there, I'd say it kind of depends on the patient, how we're treating them. I mean, some of them come in with pre-existing ocular surface disease, and they're already on serum tears, and they've had lipoflow and this and that. But so it really depends on the person. And we have a whole clinic that does MIBO and manual expression. So sometimes we may be doing that. But it really does depend on how bad the surface really looks and what other pre-existing, some of them have lid issues. I mean, just looking at the lid positioning, a lot of them have had blepharoplasty, have lag ophthalmos. So just paying attention to those things, because dry eye can stem from a lot of other either underlying diseases, anatomical issues, and kind of figuring out, what the cause is, or even that they're on 3 other glaucoma medicines, things like that. That has to be addressed.
I like what you said about showing them the testing, because that's something that you can do with some of those objective tests, and patients like following those metrics to see that things have improved, and so do we. Yeah.
It's hard to treat them all the same. You really can't treat them all the same unless you're doing a study and this is the treatment. I think it has to be somewhat customized. So
diagnosing and treating dry eye before a cataract surgery is a very important aspect, and you have brought up a really good point here to discuss. Actually, it's easy to convince a patient who already knows the patient has a dry eye, but difficult are the cases which are asymptomatic, and which, you have to convince them that, okay, this is the problem with you, and we need to start you on drops, and we need to wait for maybe a few weeks before things stabilize. And that, because when the patient walks in, patient says, no, I'm perfectly fine, there's nothing wrong. But when you do all the tests and when you detect that there's a dry eye, so that's one tricky aspect, having an asymptomatic dry eye patient in your clinic. And then we need to explain them that, okay, we need to do the same method of doing the keratometry and everything, maybe after 2 to 3 weeks, and seeing and watching the tear film to stabilize, and then go ahead. Because at the end of the day, the intraocular lens power calculation and everything, it depends upon the intact tear film. So that is a very important aspect, I think.
Yeah, I agree with that. And I like what Dr. Donaldson, you had said about, you have to look even at things like the eyelids, because we know that if you have a lot of blepharitis, that can be an independent risk factor for endophthalmitis. So it's something to consider as well. So the way I speak about this with my patients and the way I think about it is to treat it aggressively, much more aggressively than you would if it was just a dry eye patient coming into your clinic. So I talk to my patients, and what I say to them is that I have the dry eye basics, which everybody should be doing. All patients should be doing things like artificial tears and lid care. But because we're preparing your surface for surgery, I'm also going to add some prescription drops. So I'll often do a short course of a topical steroid to just really rapidly reverse the effects on the ocular surface and to reverse that inflammation, which Dr. Pierman had mentioned is so vital, kind of key to the pathophysiology of dry eye disease. Then I'll do even a long-term dry eye drop if the patient is severe enough in terms of their symptoms or their signs. So things like cyclosporin 0.05 or the 0.9%, I've been really happy with that, or lifitegrast 5%. And then looking at things like meibomian gland expression and even microblepharoexfoliation if they do have a lot of scurf and a lot of blepharitis and bacteria, just to limit any risk for endophthalmitis. The next case I want to talk about was addressing astigmatism. And Dr. Devgan kind of mentioned this even when we were talking about the diffractive lens, how you really have to kind of fix all astigmatism because if you're going to be doing premium surgery, this is a big component of it. Because residual astigmatism can degrade vision and can actually compromise the performance of some of these premium intraocular lenses. And it's not that you always have to get to zero astigmatism. That's not the goal. It's just managing the amount of astigmatism that will be visually significant for the patient. So I have a couple pearls here about astigmatism. My first is to determine the magnitude and axis, get multiple measurements because you want to make sure that you're getting good information because good information in is going to get you good outcomes for your patients. So I'll often do things like auto-Ks, tomography, and biometry for patients, and making sure that the axis and the magnitude of astigmatism are all correlated so that it does make sense that this is the amount of astigmatism this patient has. My second pearl is to consider the posterior corneal astigmatism. We talk a lot about this, and the posterior corneal astigmatism can be incorporated into your calculations with some online calculators. So for example, the Barrett TrueK, which can be found on the ASCRS website, you can actually use this to estimate the amount of posterior corneal astigmatism and that effect that it will have. And there's also some newer technology that can do this for you. And I've been really impressed with the IOL Master 700, which has a swept source OCT, which indirectly measures the posterior corneal astigmatism. And the reason why I really like this is it does it all in one biometric measurement and also does my surgical planning all in one. So it'll actually show you the axis of the astigmatism, where to place the lens. It tells you which lens and what your refractive, your residual cylinder would be. And I don't have to be inputting measurements from my biometry onto an online calculator, especially if I'm doing, high volume cataract surgery. That's a lot of transposition that needs to occur, and that is actually pretty prone for error. So I really liked having some newer technology, which just has this incorporated into it for the posterior corneal astigmatism. The reason why this is important is that there's going to be long-term drift of astigmatism towards against the rule as patients get older. And it's estimated to be at about 0.34 diopters per decade. So what I try to do is I'll actually try to target up to 0.3 diopters with the rule, especially for younger patients, because you know that they're actually going to drift towards against the rule over time. So it's actually okay to flip against the rule to with the rule. Vice versa, I wouldn't do. So I'd be really cautious doing that because they're going to develop more against the rule over time, but it's okay to flip to with the rule. So this is just showing here, this photo is an example of where I actually chose a higher power toric lens because I'm actually going to flip it and overcorrect slightly to with the rule. And then lastly, just to be, if you do have this available, to access some newer technologies that can help with lens placement. This is a Callisto system from Carl Zeiss Medica. And what's nice is that you don't need to mark the patient preoperatively. What this does is it has the axis of astigmatism projected through your ocular of the microscope. And this is based on the preoperative measurements when you did your biometry. And it actually tracks the limbal and scleral vessels. And then it displays so that even if there's cyclotorsion of the eye as the patient lies down, you know exactly the axis where your lens needs to end up. And so I found this really helpful because it's efficient. I don't need to be marking patients preoperatively or intraoperatively. And it's very, very effective. And I'm getting excellent outcomes with my toric lens placements with this technology. Does anyone have any tips about astigmatism or anything that they wanted to add at all?
Uday, do you have?
Yeah, the one to be careful of are the patients who have a low degree of myopic astigmatism who come to your office who are plano minus 150 at 180. And they're coming in and they're really not wearing glasses hardly ever. And you do their cataract surgery, be careful. If you correct them to totally spherical, make them dead on plano, you've collapsed their optical conoid. So before surgery, they had two focal points, plano and a minus 150 or minus 75 focal point. And you've collapsed those down by fully treating their cells. So some patients who have a low degree of myopia and some SIL like to retain it. So be cautious of those.
Yeah, that's when it's so important to talk to the patient and say, you know, how are you wearing your glasses at this time? Because if they tell you that there's, you know, they can see okay in the distance and they're actually reading okay, exactly as you said, Dr. Devgan, you want to make sure that you're not actually overcorrecting them. That's actually kind of a nice pearl that leads to my next case and my last case, which is when sometimes doing less is more and how not to make happy patients unhappy patients. And that was one great example of that. And I have another good example here, which is a patient that came to see me. She had had LASIK twice, so really motivated not to be in glasses, as you can tell. She's had LASIK multiple times, and she really wanted a diffractive lens. And so what's the problem with this? Well, my concern was about higher order aberrations, because higher order aberrations are distortions that are acquired as light passes through the eye that might have irregular, refractive irregularities. So I looked at her topography and it showed fairly regular astigmatism. And the patient said, you know, I'm very motivated. I understand the risk, and I really, really do want this lens. And so I was at the ACOS Aspen meeting with Dr. Trattler, and I asked him about this case, and I was telling her, but she's really motivated. She really wants it. And he said to me, you know, it doesn't matter how motivated the patient is. They're not going to see well. I just wouldn't do it. And I thought that was really, really good advice. I'm a scientist, so I really want to know why and exactly what I could tell the patient to show her why I don't recommend this lens. Not just saying I don't think you're going to see well, but I could tell her, I know you're not going to see well with this lens. And so one of my friends and colleagues, Dr. Michael Greenwood, showed me this. I don't have a corneal analyzer, but I do have a pentacam. And you can actually look at the total higher order aberration under the pentacam function to the Zernicke analysis page on the drop-down menu. And with a cutoff of approximately 0.6 for any diffractive lens, if patient has corneal irregularities, you can see on this slide here, the HOA is quite high. This is a patient that has keratoconus. So I go to my patients and I pulled hers up, and her higher order aberration totals were about 0.9. So I knew this was going to be a little bit high for her. So I could actually show her this number and say, you know, I just really don't recommend this lens for these reasons. And then she was, you know, quite happy with that explanation. So I totally agree. Sometimes doing less is more, and just focusing on keeping your patients happy. So those were my cases that I had. I wanted to thank you guys. This is a picture here of some of the graffiti that we've had in New York, some eyeball graffiti that's been found all over since the pandemic's occurred and some of the stores have closed. And I wanted to close with just playing this little clip from the Raptors when they were in the playoffs. This just happened about a week ago. They're no longer in the playoffs, unfortunately, but this is a player that had, with 0.5 seconds left, made a three-pointer that won them the game to keep them in the playoffs at the time. And this is, I think, is a great attitude, not only to life, but a great attitude to have towards surgery. So I'll just play this for you.
Hey, OG, maybe a stupid question, but just watching, like you showed no emotion after you hit the shot. Like, how did you stay so cool after such a big play?
Because my shot, I expected to make it. So like, I don't shoot trying to miss. Like, every shot I shoot, I try to make it. So I was not surprised. I wasn't surprised.
So he says that he wasn't going to act surprised because he wasn't surprised. Every shot is to make it. And that's kind of what I think our attitude should be towards surgery. Even if your patients aren't getting premium lenses, even if they're just monofocal lenses, our patients have extremely high expectations for how they're going to see well after surgery. And so I think continuing to practice, prepare, and plan will get you to that point. So thank you so much.
Fantastic. Thank you so much, Ashley. This has been absolutely brilliant. Could you stop the share so we can start a discussion or have some Q&A? I think we do have some questions from the audiences as well. Jen, would you go ahead and ask the question?
Yes, and yes, I agree. Wonderful talk, Ashley. I learned so much. But I do want to bring up a couple of questions from our audience. Someone did ask if you consider preoperative dry examination to be standard operating procedure prior to cataract surgery? And obviously yourself and any of the panelists can jump in.
Yeah, so I actually do. I think people are afraid that this is going to take a lot of time away from the clinical encounter or maybe even slow down the efficiency of clinic. But I find that if you kind of have a streamlined approach to it, it shouldn't take too much time away. I don't employ standard questionnaires. Instead, I just ask directed questions, and my technicians know how to do this even in the standard workup. And then using some of the objective measures, I think is helpful. So like the tear osmolarity and the MMP9. And then as I clinically examine them, I'm going to stain the surface. So it actually doesn't take me that long to do a dry eye or an ocular surface assessment for these patients. So I think it's just standard part of cataract surgery.
Oh, great tip. Another question, from the audience as well, and this can go as well to the panelists. What tips do you give to residents or fellows when they ask you how they can be more efficient in the operating room and in surgery?
Yeah, the one thing I always say is first you get good and then you get fast. And that's the advice that I give to my residents. So you need to master the skills, you need to learn the steps, be good and efficient and methodical with your movements, and then the speed will come.
Yeah, good point. I'd say don't ever worry about speed. It's about efficiency, not speed. Speed leads to issues. But you can cut out inefficient steps of surgery. Like, you don't need a cystotome, just do the rexus with the forceps. You don't need to do divide and conquer, just chop the nucleus. And so if you do these cut out superfluous steps, you can really bring down the surgical procedure to something very efficient and very pretty.
You know what,
I have one. Oh, sorry, please.
I was going to say, it's nice to observe your colleagues. And when I first started out, I remember going to observe Dr. Trattler, but I went to see, several of my colleagues in different practice settings. And I would find one thing I liked about what someone was doing, and then something else I'd find, at someone else's practice. And then you kind of make yourself out of those things that you find. You can always take something interesting and good and put it all together to decide what works best for you. So just observing, and fortunately we have YouTube now too, but it's always nice to go and visit different practices.
I have just once, oh, sorry, carry on.
I was making only one pro from watching me. I'm disappointed.
We'll talk about it later.
Okay.
I have one small tip that when you are in the OT for the residents, just focus and just observe on the hand movements of the surgeon and how the surgeon is doing. The entire trick lies there, how the movement of the hand, the transfer of the instruments, the decision making which is going on table. That is the main thing that really helps you out. I think if you focus on that, the basics you are going to find everywhere. But this is a very important surgical point. At least it works very good for me.
Priya, fantastic point. So we do the same thing. I actually shoot double camera angles. I do a video where I sync up the side view of the surgeon's hands with an inset picture of the video of the microscope view. And so I have many of those videos where you see both at the same time. So it does certainly help a lot, because otherwise the microscope view doesn't show you what the hands are doing.
Correct. That's the hand movement is the main movement which is going on.
Guys,
absolutely.
There is a huge element of patient expectation and the IOL that you're giving, especially in the refractive cataracts age group that we are talking about. What is your tip and suggestion when you have a patient who is who's already asking a lot of questions and is tending towards more of a unhappy patient at the end of whatever you try and do it for that person? How do you try and lower the expectation, or how do you try and meet the expectation of that patient? What is your tips and tricks on counseling this, the way out of this? Uday, I know you have a lot of tricks up your sleeve, so we'll come to you very, very soon. Go ahead, if anybody wants to go.
I don't have any tricks, but I tell a patient, I appreciate that you're so well read and you've done so much Google homework, but there's no way for me during this consultation to make you into a junior ophthalmologist. So at some point, my best advice is find a surgeon, tell him or her what you want, and then just give them the trust and the ability to do what's best. And the example I give to residents is, you're a brilliant MD, you were AOA, graduate med school with highest honors, you're this brilliant ophthalmology resident, But if you had to have a hip replacement tomorrow, and the orthopedic surgeon said to you, Ashwin, do you want the ceramic coated one? We have the titanium one. We have the fenestrated. Which hip implant do you want? That, I don't know. You'd say, listen, I'll pay whatever it costs, but I want the best thing for me and my needs and my anatomy. And that's what patients should do with you.
Great advice. Great. Kendall, Priya, Ashley.
I was just thinking, about some of those patients that can be really challenging like that. You have to remember that you're the one in charge and you're the surgeon, and don't let the patient make you do something that you don't feel comfortable with doing.
Right.
If you truly believe that the multifocal lens is not the best for this patient, sometimes they will try to force you to do something. And it's true, as Uday said, they're not the ophthalmologist, and you have to tell them, this is what I recommend, and this is why I recommend it. And I can't give you, and maybe you have to optimize the ocular surface, but sometimes they're still not appropriate. And you just have to do what you know is best for the patient and what's right, and don't let them force you to do something that you're not comfortable with in the long term. And sometimes that can be tough, especially when you're young. I'm not young anymore, but when you are young, and you're just starting out, it can be tough because they will try to force your hand sometimes.
Perfect. Yeah.
I think always when we are explaining about patients, there is always a limit where we reach up to a point beyond which, the patient does not seem to understand what's actually there. There are certain very tough situations where the patient is not even ready to accept it. So even after I've tried my best explaining them, I would just end up saying that I do not recommend this. If you want it, I can do it for you. But I would advise you to go against this because this is not going to help you out. Now, coming up to this, I've lost many cases, and probably they've got themselves operated somewhere else. But then at the end of the day, I always try to remain true to my patients. I've never done things in my life which I actually am not convinced about. So I do it that way. I just leave it out there.
Ashley, do you have any tips?
Yeah, when I started as a young surgeon, I remember my chairman said to me, just remember, you don't have to operate on everybody that wants you to operate on them. Yes. And I thought that was a really great piece of advice, because I think you'll avoid
That's a wise person.
Yes. Yeah, and the patients will always be there, and patients will come, and so don't be too hungry chasing every piece of surgery that comes to you when you start, that you get yourself into trouble.
Yeah, absolutely.
What is the minimum, what is the bare minimum astigmatism that you treat? This is a question that's come up on our live chat. So what's the bare minimum threshold that you treat astigmatism with, and what's your best format for it? I mean, this is an additional part of the question that I'm adding. Do you do it with an IOL implantation, or do you do it as a laser later on? What is your approach?
So for me,
go ahead.
Okay, I was just going to say, for me, it depends if they're with the rule or against the rule, because I said I like to leave more with the rule than I do against the rule. And then if it's a low level of astigmatism, I actually like doing it with the limbal relaxing incisions with the femtosecond laser. The LRIs don't rotate. They're stable. They stay where you place them. And I've had really good success with that, especially if you're using a diffractive lens. And the technology of that lens works well when you really, really minimize the amount of astigmatism that's there. So if it's a low level, we don't have lower level torics in some versions of certain lenses. We do have others. So I'll use LRIs fairly often for these patients with lower levels.
Right. Kendall, Priya.
If you have a half diopter of SIL, I'm going to address it. Mm-hmm. I want you as close to spherical as possible for the best results now. In the US, the lowest toric lens we have from any of the companies corrects about 1 diopter of the cornea. We don't have the lenses that correct 0.6 diopters of the corneal plane. And so we have to do incisional approaches, either placing your phaco incision on the steep axis, combining it with an LRI, or even doing paired full thickness phaco incisions. But you owe it to yourself to really nail the target as best you can. And if you put in a lens, like a diffractive type lens, trifocal, multifocal, what have you, and you're off, you have to eat the cost and do their LASIK or PRK and get them on target. And let me teach you how you say it. We did the beautiful surgery for you, the correct lens calculations, but the way you healed is not good. You're not a good healer. So don't worry, even though you're a bad healer, for free, I'll do your LASIK or PRK and I'll get you spot on. Don't worry.
Perfect. I think that's great. Good advice. It's really good advice. Kendall.
Yeah, I mean, I would agree with everything that Ashley and Uday just mentioned. I mean, of course, you have to take into account whether it's with the rule or against the rule, and you're gonna want to leave a little with the rule. So, and it also depends on whether you're using a multifocal lens versus a monofocal lens. And of course, you have to take into account the patient's visual potential. I mean, if they have 2200, macular potential, I'm not going to be charging them the extra money for doing my half a diopter limbal relaxing incision. So, again, I think you have to take into account the whole picture. And I mean, of course, we don't have the T2 yet, but if we're on the border between 1 and 1.25 diopters, I'm always going to err on the side of the toric lens if because it's going to be more stable long term. But yeah, we need to nail it, and you have to take all those things into account. So each thing is individualized and customized for each patient.
And we didn't talk about angle alpha and angle kappa with regards to these refractive ring lenses, but that's a whole nother topic.
Yeah, I feel like you could do a whole discussion on some of these.
We can have a whole webinar on it.
Yes, exactly. Yeah. The one thing I think that I've learned a lot as I've been in early faculty is the importance of communication. It's really how you communicate things with patients. And I think some of these great tips that we've heard even from the panel, it's really just in how you say things to patients and how you can help them understand how much we understand about it, and the language that you can choose to help them get to that point where they feel comfortable making a decision and you feel comfortable recommending something to them.
Great. Priya, you want to say a few words, because we have one more question which we'll take and we'll close after that.
No, I think I'm fine with. We can go on to the next question. Okay. I think everything has been covered.
Okay. Well, one of our last questions we got was, in general, what type of patient do you recommend femtosecond laser surgery in? Now we know most of us are using femtosecond in premium lenses like torics and multifocals, but is there anyone else that you would recommend it in general?
So I'm the exception then. So we have 3 femtosecond lasers in our surgery center, and I use them about 1% of the time. And so I use it in cases where it's really going to make a difference, such as maybe an intumescent white cataract, terrible zonular support. I had a patient recently with the AC depth was 1 millimeter. It's going to be tough to make a manual rhexis, but with the femto, it's pretty easy. So I use it for clinical situations, and I don't charge a nickel extra for it. So if I think you need it, I'll use it. If I don't think you'll need it and it won't benefit from it, I got these magical forceps, and all I do is that, and I'm done.
Dr. Uday, you have a new fan. I'm your fan now.
Don't tell anyone.
Kendall, I'm sure you have it with you.
That was a good point, Uday. You can't charge for this femtosecond laser, so it's just, for us, it's just part of our refractive cataract package. So anyone that's getting an upgrade is getting the femto laser, but we're not charging for that. If we do it in a case like the white cataract, we just do it for free, basically, as a tool. So for those cases, like you said, the zonular issues and things like that, we're not charging for that. It's a nice tool in those situations.
I learned that from Billy Tratler right there. Seriously.
Me too.
I mean, I will say that some of the lasers now have the ability to incorporate preoperative topography and axis and astigmatism and put little marks on the capsule or on the cornea. So that's what I know. Dr. Lowe and I both have that technology at our center. I know the Catalyst is coming out with that soon. I think some of the other femtos are as well. So that'll be game changing for astigmatism correction.
Right. Ashley, do you use them? And
I do, yeah. So I'm lucky we have access to the femtosecond laser at my surgery center. And I do use it. I think it's great, as already mentioned, for some of the complex situations. So like the white cataracts and lack of zonular support. And then also I do like it for creating LRIs. So if patients have low levels of astigmatism that I can't, it's at that point where it's not quite a toric lens, then I'll use it in those situations.
So all I'm hearing, I mean, from the culmination of this is that everybody is using it for a particular indication or a particular set of patients, and that's about it. It's not that everybody's using it for every single, which is a little confusing, because I'm trying to see where I can actually use this, but I'm not getting the right answers from everybody. So it's good to know at least that there is a set of indications where you actually go ahead and use the femtosecond, and that's good to know. But I love the Uday's point that you do this and this, and we're done.
You got it.
Okay, but thank you so much, everybody. I think we are going to need to close because we have exceeded time today. But it's been an absolutely refreshing morning start to the day for me, and a good night for you guys where you are. But happy to have each one of you, Kendall, Uday, Priya. Thank you so much for being there. Ashley, you did an absolutely phenomenal job. Laura, thank you so much for your few tips and pearls in terms of how we treat dry eyes and how we take it forward from there. Jen, Bill, thank you for helping me moderate today. And most important, we are going to show this. Reruns are already on your website. It'll be there in the next 24 hours. More than that, our next episode is going to be on the October 20th. And we're going to have Dr. Lawrence Woodward on the show, as well as 3 celebrity panelists. That's a surprise package for you guys. But happy to see you in the next episode of Rising Stars in Ophthalmology Season 1. Thanks.
Congrats,
Bye.
Ashley.
Thank you.
Thank you. Thank you, everybody. Thank you. Have a nice day. Bye.
Bye.
Right, guys.
Allergan has always built their reputation on their R&D pipeline. I trust Allergan that they have the next big thing that's going to come out.
We're working on a lot of innovative therapies.
Better pathways, better innovations to help treat the disease process.
There's really just one company that keeps reinvesting, giving us new options for the future. It's Allergan.